All right. Thank you for joining and listening in on this panel discussion. Earlier, we recorded a presentation about our bill for modernizing our collaborative practice authority here in North Carolina. This is the session that accompanies that presentation and involves a panel of pharmacists from across the state. And at this time, I'm going to ask the panelists to introduce themselves. We're going to go alphabetically, and I'm going to ask Jay Campbell to lead us off.
I am Jay Campbell. I am a pharmacist and an attorney, and I'm the executive director of the North Carolina Board of Pharmacy.
I'm Christie Dresbeck. I am the clinical manager for our ambulatory services at Mission Hospital's Health System in Asheville, North Carolina.
And I'm Lisa Edgerton. I'm the residency program director for the PGY2 ambulatory care residency at New Hanover Regional Medical Center in Wilmington, North Carolina.
And I'm Joe Moose with Moose Pharmacy in Concord, North Carolina, Cabarrus, Rowan, Stanley County area.
I'm Christina Nunemacher. I'm a clinical pharmacist working in the community with Relo in Jacksonville, North Carolina.
Hi, I'm Mollie Scott. I'm the Regional Associate Dean for the University of North Carolina Eshelman School of Pharmacy and work as a clinical pharmacist practitioner at Mayheck Family Health Center in Asheville, North Carolina.
I'm Greg Vassle. I'm the owner of multiple community pharmacies located in central North Carolina. And over my career, I've kind of owned or participated in helping build about 17 community pharmacies across North Carolina.
Great. I'd like to thank each of you for joining us today. And I'm going to go ahead and jump into the questions for the panel. So our first question is actually specifically for Joe Moose, who represents community setting, and Lisa Edgerton, who represents an ambulatory care setting. In your opinion, what is the potential positive impact of modernizing our collaborative practice for your specific practice setting? And Joe, we'll have you go first.
Okay, thank you, Penny. Yeah, you know, it all starts in the community, and that's where our patients are to start with. So by allowing us to collaborate, we can head off care before it gets to the most complex and the most expensive point of care, which is typically our health systems and our ED visits. So there are a number of opportunities, I think, to leverage the relationships that community pharmacists have with the rest of the medical community in a way that will give us a positive outcome. So I think for so long, we've all kind of worked on our own metrics. And so community pharmacy has their metrics, hospital pharmacy has their metrics, AmCare, you know, physicians and clinics have their metrics. And as long as we're all working on our own metrics, we don't kind of move the force all together. By having collaborative agreements, we start to bring all the same metrics in-house where I'm concerned with what the doctor's metrics are and they're concerned with what my metrics are, and we can all work together to achieve these metrics. So in terms of getting better outcomes for our patients, I think it's really obvious the benefits of leveraging these relationships to do that. It's in terms of efficiencies in the healthcare system and helping with cost and those type drivers, it certainly builds efficiencies. As recently as all the blood pressure medications where losartan became unavailable, just the act of changing that to one of the available drugs that are in the same therapeutic class became an administrative burden for the pharmacies. It became an administrative burden for the practices. Everybody involved, and there really are not an efficient way to date to make something like that happen easily without building efficiencies in. So something, you know, as simple as that example that seems to be happening more and more frequently to something as complex as is a collaborative agreement where you may be doing long-acting antipsychotics. I'm right outside of Charlotte, North Carolina, less than 20 miles from Charlotte, which is about the 17th largest city in the United States. And we have patients who have to go to the emergency department to get a long-acting injectable injected because the psychiatrists, the primary care doctors don't have nursing staff to do it or don't have access to the drug to do it. And they're actually one of our healthcare organizations around here that deals with behavioral health patients lost their nurse to nursing shortage, so they're sending their patients to the ED to have these injections done. So a relationship there certainly would help with patients that we're seeing and patients that we already have relationships with by making more access to care available.
I love some of the things that Joe said, particularly about moving the needle in a community by everybody getting collaborating and getting on the same page. You can really move needles in healthcare, I think. I also love some of the things he said about access, and I think that is where I really feel like by modernizing this bill, we can have a positive impact. And in my setting is access to providers. We in North Carolina, I work in Wilmington, and we have one hospital here that serves really a 7-county area. And so we've got patients coming in from all over the place because this is where sort of the big hub of the physicians are. And so if we could get people, pharmacists, with this collaborative practice out in those areas, we might have patients that could have quicker access to care, expanded access even. So some of it is hour-based. So physicians have very limited currently, most physicians have very limited hours. And so having pharmacists, potentially even in community pharmacies with some collaborative practice, could increase someone's insulin, for example. So if they are reporting blood sugars at home and they know they're uncontrolled, sometimes to get to a physician in Wilmington or New Hanover County may take 2 or 3 weeks to get in to just report blood sugar numbers and have a titration and an insulin dose. So those community pharmacists could greatly help take care of those patients. The other thing that I think it could do is free up some of the higher acuity visit needs for physician offices. So the physicians we know are burnout. They're seeing lots and lots of patients. And in this area, we have such few of them, we have to keep the ones we've got. And we need them to be happy and positive to continue to recruit more people to this area. So we really need them to spend time on those higher acuity patients or have available slots to get more patients into the physician's offices. And then hopefully, if they feel like they are truly having this value and collaborative care, that it's really team-based and they have extenders out in the community, they'll help we reduce the burnout in this area.
Great. Thank you, Lisa and Joe. Our second question is for Christy, Christina, and Greg. What are your thoughts about modernizing our existing collaborative practice authority to be more open, meaning who can collaborate, and also having less restrictive language regarding what can go into a collaborative agreement? And let's start with Christy, and then Christina, and then move to Greg.
I really appreciate the opportunity to talk through. I echo what Lisa and Joe were saying as well in terms of here in Asheville, though we are centrally located as a mission health system, we serve a very large region, almost 16 counties, with over 20 primary care clinics. And in terms of how the structure of those clinics changes, provider burnout, we've noticed that a lot of our clinics really utilize our embedded pharmacy resources, especially when those pharmacists or when those clinics have fewer providers. And to help shore up. So our pharmacist providers are not able to be supervised by nurse practitioners or PAs, or there's just not as much of an ability to have that collaboration. When we first started with CPP, most of the time our providers were strictly physicians or DOs who had their primary care panels. Well, now in primary care, with the accountable care organizations and value-based management, we have nurse practitioners and PAs alike who have panels that they have to take care of. And so in terms of the language and the restriction, depending on how our system may read the legalese, there can be some interpretation there in terms of how we can help manage those nurse practitioners and PA patient panels versus how we do the providers. And I think that, again, it speaks to what Lisa was saying in terms of we need our providers not to leave. We need them to stay there. So allowing us to do more co-visits with nurse practitioners and PAs, allowing the other providers to have an increased access. There's a lot of opportunity that our current system doesn't allow us to do. In terms of less restrictive language, some of the things that we run into personally in terms of trying to help with system provider burnout, for example, we have a refill authorization and prior authorization program. We have 20 physician practices in our 16 county region that we serve, but with the restrictive language around how many pharmacists a physician can supervise, we're really trying to get very strategic. And so I'll be talking with Jay probably in the future, unless things change, about how do we strategically allow us to provide these collaborative practice refill programs throughout the region, but do we have 5 physicians that supervise 15 pharmacists? It gets to be a bit nightmarish when we start thinking from a system and a population health perspective. And so the legislation that we have now and the way the statute is written just hasn't grown with us in the way that managed care and population health has. And so I think all the more reason, as much as we can be open, to allow us to be more innovative and grow with how healthcare is changing, the better off we can be.
Great. Thank you. Christina?
So, just to kind of bounce off what everybody else has said, I think that this is a step towards recognizing the role of the pharmacist in the care continuum. Because right now, as a profession, we have this extensive knowledge base and clinical abilities, but we're sort of in the shadows because we can't expect physicians and health systems and mid-levels to recognize what we can do when our own rules and regulations don't really underscore what we can do. So we need to reflect what we're capable of. And I think as the rule stands right now, it sends a message that we really aren't ready to be part of that team. And we need to send a better message. I think as a profession, we need to do that, but it's really tough for us to go out and show what we can do when we have both hands tied behind our back. So I think it's a great step. And I think it's, North Carolina, I'm originally from Pennsylvania, and looked at North Carolina as this really sort of progressive state. And when you kind of step back now and you look at collaborative practice, it's time for North Carolina to catch up with the rest of the country.
Greg?
Yeah, so I echo what everyone else is saying as well. I can only speak for community pharmacy because that's where my background is, but in my practices, I'm trying desperately to train my pharmacists to become more than simple dispensers of medicines. And also, with all the work that I'm trying to promote, I'm trying to get our brick and mortar pharmacies to transform into integrated healthcare hubs that work collaboratively in a horizontal fashion with other providers in our local communities. So in essence, what we're trying to do is we're trying to bring in a clinic inside of our pharmacies and offer an on-demand healthcare experience, a preventative, retail lab type of, element, and then also the collaboration. But we have to do all these things because we don't have a strong collaborative practice agreement in sight. And so, in my opinion, great healthcare is locally provided. And, what works at our coast is going to be vastly different than works in the mountains. And, being an owner in some of these areas, throughout my career, I kind of know this, is happening. And so with better insight and working, elbow to elbow with some of the local providers, within the constructs of a modernized CPA is kind of the glue to kind of make this transformation to a healthcare hub, particularly in the rural areas where we need access and affordability, and also be able to kind of help promote preventative things for our, patients, is only the way to kind of move forward.
Thank you. The third question is for Jay Campbell. When mentioning our proposed any pharmacist, any physician ability to collaborate, occasionally someone will raise concerns about public safety or qualifications, yet 33 other states have implemented a more open and less restrictive collaborative practice authority. How do you respond to concerns about public safety?
Let me back up and pick up on one thing, Christina, a point Christina made that I think is a good segue into this, is that we've had collaborative practice for 20 years, and there was a time where we in New Mexico were way ahead of the rest of the country on this. And my bet, Penny, is that in 1999, when there was first discussion of a CPP-based collaborative practice opportunity, that there were probably many of the same sort of, oh my goodness, is this going to cause harm to the public? And that sort of anxiety sort of comes in two forms. There's the external anxiety, I guess, by those who are not part of the pharmacy profession, who will raise concerns and say, well, are pharmacists qualified to do that? How is this going to work? Are my patients going to be harmed, et cetera, et cetera? But there's also the internal anxiety, which is pharmacists themselves, who are concerned about whether they feel personally they have the skills that are required to practice in a collaborative way, or they may remember a colleague over their years who they had a less than positive view of their capabilities and sort of project anxieties about collaborative practice from the standpoint of the worst possible example. And that's always a part of an advocacy and legislative process, is teasing through these things. But I think sort of the proof is in the pudding, right? I mean, it's normal to have these sorts of anxieties about public safety, and after all, none of us are interested in endangering the public as pharmacists. To the contrary. But it's really in many ways the dog that didn't bark, right? We've had collaborative practice through CPPs in North Carolina for 20 years. And the grand total of CPPs who have ever been subject to discipline for alleged patient harm in those 20 years is 1. And even that wasn't a direct patient harm. That was more an issue of frankly, an issue where a supervising physician probably did not exert the type of oversight that he should have. There was actually no proof of any patient harm at all. And then you're right, 33 other states over the years have implemented collaborative practice authority that ranges from something very similar to our CPP, and that it adds on a number of additional qualifications and experiences, and maybe is fairly prescriptive about what can be done, to the models that can more or less be stated as if you as a licensed pharmacist and you as a licensed physician can reach an agreement to treat patients and delegation of authority on that, then by all means do that. And I'm not aware, at least, that in all these other states that have begun that, we've certainly seen a crisis of patients harmed in any way. In fact, I suspect exactly the contrary is true for all of the reasons that the other panelists have discussed about how these sorts of opportunities can improve the public health and safety. So I just don't think there's much of a case to be made that collaborative practice agreements among qualified, competent healthcare providers who decide amongst themselves what they are capable of doing and agree to supervise that and work within those constraints. I don't know what the real risk is. Certainly there may be individuals who are themselves not comfortable in engaging in collaborative practice. Fair enough. The opportunity for collaborative practice is exactly that, an opportunity. Some folks may wish to take advantage, others may not, but that's certainly not a reason to say, well, if everyone's not going to be comfortable with collaborative practice, then no one should have the opportunity to do that. So I think we were the leader for a lot of years, and the positive experience of CPP practice in North Carolina, I'm quite certain, was a motivating factor for other states to have their own collaborative practice authority. And I'd be willing to bet that a lot of those states pointed and said, you know, North Carolina's had this for 10 years, and yet we're not hearing any bad patient outcomes or patient harms. So maybe it's our turn to point to the example of the other states and use that same argument.
Thank you, Joe. Our next question is for Mollie Scott. Mollie, you've already heard a couple people mention that it's been over 2 decades since North Carolina first established our Collaborative Practice Authority. And although we were a pioneer in this area, today North Carolina has been referred to by national leaders as having one of the most restrictive collaborative practice authorities. As a leader in pharmacy at both the state and national level, can you give us your perspective on the importance of this bill for North Carolina at this time?
Mm-hmm. Thanks, Penny, and I'm glad to be here to comment on this. I think that as a state, we have the opportunity to really modernize our collaborative practice agreements. And as others have stated, you know, we were leading the way decades ago in establishing collaborative practice agreements, really as pioneers in this area. And we haven't really looked at this again in detail to ensure that the CPP credential has remained contemporary or has caught up with healthcare transformation. And so as time has evolved, other states have come on board and have created their own collaborative practice agreements that work for their state, and national organizations have published papers on what collaborative practice agreements should look like. And we have a lot of advocacy for collaboration between pharmacists and physicians from a wide variety of organizations such as the CDC and the Patient-Centered Primary Care Collaborative and the National Governors Association and so on and so forth. And what's happened in the past 20 years in healthcare has been dramatic. You know, we're seeing major disruptions in healthcare with significant changes that we need to make to the U.S. healthcare system in order to improve quality and lower cost and improve patient satisfaction and provider satisfaction with the quadruple aim that they were all working towards. And we see changes with reimbursement models. We see transition from fee-for-service to more of a population health management, value-based care. And so it's important for the profession of pharmacy in North Carolina to look at these trends in healthcare and to look and see what other states are doing to advance practice and making sure that we're prepared to really provide these high-level team-based care to participate in those types of models in a wide variety of settings, you know, in the hospital setting, in the community pharmacy setting, in the ambulatory care setting, and long-term care. And I think that the CPP credential has worked well for ambulatory care pharmacy. I am an embedded pharmacist model, and I think it has served us well in that particular environment. But I see lots of practice areas where this model doesn't work quite so well. So, you know, what other states have done is they've created these models of, you know, collaborating physicians working with collaborating pharmacists to do a lot of different things to tackle contemporary healthcare problems. And that's harder for us to do in North Carolina with the way that the legislation is written. So, you know, I think one of the reasons that I'm really supportive of this bill is I see that it allows pharmacists in North Carolina to do more of the things that we know that we can do. And for instance, as we think about contemporary healthcare models, it would enable us to provide more collaborative care and long-term care environments, in transitions of care, in community pharmacy settings, with other prescribers other than physicians, because it would open up the doors for us to collaborate with PAs and nurse practitioners. A lot of our CPP models have been limited to urban areas. And so when we look at the data about where CPPs are, they're not in rural North Carolina. And those are the underserved patients who desperately need chronic disease management and who need the expertise that we have. And so I see this effort as a forward-thinking, proactive attempt to ensure that something that we've had that's really good and that has served us very well is now keeping up with what's happening in other states, that's keeping up with what's happening in healthcare transformation, and most importantly, will have a broader availability and a stronger impact on North Carolinians.
Thank you, Mollie. I'm going to move on to our 5th question. This one is for Lisa Edgerton and Joe Moose. One of the concerns that has been raised about having a more open collaborative practice bill is the possibility for the retraction of pharmacist jobs. As someone who works in more of a health system setting, Lisa, and for you, Joe, in a community setting, do you two have the same concern, or do you see a potential for expansion of jobs? And could you elaborate on that? And let's start with Lisa and then go to Joe.
Sure. I personally have no concern at all that modernizing this bill would be have the possibility of retraction of jobs, and I see it quite as the opposite. I really feel like this would be additive and help start to close a huge gap in access to primary care. And when I think about my own practice as a CPP for 15 years, I only saw about probably 5 to maybe 8% of the total patient population of the practice that I was embedded within, very similar to Mollie. And when I think about CPPs within our health system that I work at, same thing, probably less. If you look at us as a whole, we are seeing such a small population of the people within that their health system serves that if you made all 12,000 pharmacists CPPs, you probably couldn't close the gap that we see down at least in this part of the state. So I think that potential expansion is much more likely than a retraction of jobs. In fact, once I started really thinking about that, I can already name some sites and some locations that I know will be on board first thing, and then potentially add in positions, because people are going to hear about that and they're going to say, this is the answer. This is the answer that I've been looking for. So it's going to formalize existing relationships, but I think that shared team model approach is going to open up many, many, many new ones in the near future.
Joe?
Yeah, I totally agree with you. You know, and again, this gets back to the fundamental reason for doing this. This is not about bragging rights. This is not about our state leading the way in pharmacy. This is about taking care of the people in the communities we serve. And it really is about nothing more than that. And the system has changed so over the years that the system we operate in now makes it very, very difficult when we stay in our own lane to take care of the people. Like Mollie said, healthcare has changed. We have to do a better job of that. And to do that, we have to get outside of our four walls, whether that's virtually or with, you know, actually getting outside. And so I think the jobs will do like all economics. The jobs will follow the dollars on it. I know right now I can't afford to hire more pharmacists just to fill prescriptions. The dollars aren't there filling prescriptions. The dollars are there to take care of patients and to prevent the expensive healthcare consequences that come with hospitalization and ED visits. So I can hire people to help with that side, help on the medical spend side of things. That's, you know, that is where the biggest opportunity, that's where all the gaps lead to. And so that's where the opportunity for savings are. So I would say that I would have a hard time understanding how this would hurt the job market and would only help the job market.
Thank you. Question 6. This one is for Greg and for Christina. There's been some external stakeholder interest in pharmacists and physicians using collaborative care to help with a number of public health needs, such as treating flu and tobacco cessation and our opioid epidemic. Very few community pharmacists are currently engaged in collaborative practice agreements. As an owner, manager of a pharmacy within an innovative community practice, how do you see collaborative practice agreements assisting with the development and implementation of new types of patient care services? And let's start with Greg and then move to Christina.
Sure, thanks, Penny. So the way I look at it, and I've got a financial background and also a pharmacist, and so I kind of analyze these things in a pragmatic manner. But the business model of pharmacy, you know, is forcing pharmacists just to be retailers. And so, you know, with with that, it's the complete opposite of what we're taught in school to be clinicians. And so, the model of fee-for-service is changing, into value-based medicine, and it's changing that dynamic, which, with time, I think you're going to start to see a lot more community pharmacists sharpen their skills and engage their local providers, under a construct of a CPA. I look at it from the payer, from the provider, a lot of different angles to kind of see why they're not entrusting pharmacy necessarily to kind of promote what they should, or what we could be doing. There's insurance barriers, there's trust, there's competency requirements. They want to feel comfortable engaging with the pharmacist down the street for clinical care. I think with time, we're going to prove to them that, we have proficiency, accreditation, training, and you're going to start seeing a lot more CPAs tying us all together in pursuit of the quadruple aim. And so with the quadruple aim, providers need to have better outcomes. They need, to have, improved clinical effectiveness. They need to lower costs. They need to improve patient experience. By seeing 22 patients a day and, being under overwhelmed with everything, it's hard for them to lift all the other quality metrics. And so in my mind, pharmacy is a perfect partner for them to help, deliver value-based medicine, to a large population.
Christine?
So obviously, I think all of us agree this would have a tremendous impact. And my location is about an hour away from Lisa, and she summed it up really well in the beginning when she said that, there are patients who wait weeks to see somebody. And that's a regular occurrence in my practice to see that. And it's extremely frustrating. So we know that financially we would expect that impact. We know that we would expect these outcome measures to be hit. We know that we would expect overall healthcare expenditures to decrease. But I think there's another piece to this, and that is, Joe was talking earlier about long-acting antipsychotics. We serve a huge behavioral health population here. Vast majority of them are also opioid dependent. So as we have providers who are looking at doing medication-assisted, addiction therapy, I think about this and I think, who would be better to help with that than a doctor of pharmacy, right? It just makes sense. I mean, we're obviously the answer. I think Greg just said, we make an obvious solution to this. So if you imagine an appointment-based model where a patient can come get to their pharmacy, which is much closer, they can get their injection, or, now with the new newly approved inhaled antidepressant, that has to be administered in a physician's office. So maybe that could be done in a pharmacy. And at the same time, they're picking up their maintenance meds. And you're also addressing some of these other quality measure issues. Patients aren't taking up time in the office, and they can physicians can focus on those higher, moderate to high complexity patients or more urgent issues. So we're maintaining the patients at the pharmacy. We know we're seeing them. We know we're easier to get to. We know there's more of us available in the community. It just makes sense. And so when we think about the impact that it has, and we think about financial impact, obvious, but we're also thinking about patient satisfaction and their satisfaction with quality of care. Then we're thinking about, personally, our satisfaction and the satisfaction of the providers. I just left a meeting with a provider who's extremely frustrated because, as Greg pointed out, they can't do all the things that they need to do, and they really would like some help doing that, help meeting those measures. We are absolutely qualified to do that. So if we can eliminate burnout and we can increase patient satisfaction and help with, financial costs, to me, that's a win-win.
Great, thank you. This next question is for Jay. Jay, along the way, I've had several people ask about why X is not in the bill. Usually the items that they're asking about are details needed for enacting the law. An example includes, why isn't information about, how often a pharmacist needs to meet with a supervising physician? And does this mean that our new bill is doing away with supervision? In general, I think there's some confusion by a lot of pharmacists as to what is in the legislative process versus what is in the regulatory process. In my pre-recorded presentation, I tried to illuminate the general difference, but would you take a few minutes to comment on the role and the general steps of the joint rules-making process between the North Carolina Board of Pharmacy and North Carolina Board of Medicine, assuming that our bill does pass, as well as would you also comment on the importance of not overly regulating or building in too many rules?
Sure, and I think there are two things here with regard to what statutes ought to look like. One, you correctly identified that I think sometimes there's a completely understandable lack of understanding about the difference between a legislative process and an administrative rulemaking process, what each are intended to accomplish. And I think you combine that too is, let me sort of talk about a philosophical issue, is that pharmacy, we know, grew up, as it were, as a profession that was largely about distribution of product. So when you look at statutes that govern the practice of pharmacy and understand that's the background from which they emerge, you start to understand why pharmacy statutes tend to be fairly granular in their content. Because if you're talking about things like what kind of record to keep for this or how labeling should appear and the like, all geared toward product-based stuff, I still don't think it's a good idea to have that level of granularity in a statute, but you can understand where that comes from. And here what we're talking about is regulation of professional practice. And the model of drafting legislation that may or may not have been the right one for product-based regulation absolutely does not work when it comes to the regulation of professional practice. The Medical Practice Act, for example, doesn't say, if you wish to perform an open heart surgery, here's a 30-part listing of all the steps you have to undertake in a statute to perform that surgery, right? You're authorized to practice medicine, and then you are expected to practice to the standard of care that a reasonable physician would be held to. And so that's sort of the background on this, is a lack of familiarity and therefore a lack of comfort oftentimes from pharmacists about this notion of giving you the authority to go out and engage in truly professional practice that is not keyed to the distribution, not directly keyed anyway, to the distribution of a product. You have to be left room to practice your profession. And think about the things we've been talking about, the weaknesses or the outdated aspects of the existing clinical pharmacist practitioner statute. What are the things that folks think need to change? What's all these very highly prescriptive things that are in the statute? A statute should simply, in this context, set out an authority. What is it that the state is going to allow you to do that you've not previously been allowed to do? And that would amount to engaging in medical acts, that's the term of art in the Medical Practice Act, in collaboration with a physician as a pharmacist. A statute, one doesn't need to get into the quotidian details of exactly what that agreement must contain. Does it need to be on peach color paper or filed in triplicate or signed on this corner and all those sorts of things? I don't think they need to exist at all, but they damn sure don't need to exist, sorry Joe, in a statute, because anything you bake into a statute, you better be prepared to live with for 20, 30, 40, or 50 years. So you bake in this kind of granular detail about how to practice. I hope you like it, because it's unlikely to change. Again, look at the CPP statute we have. Now look, I fully recognize, I don't want to be overly critical of the existing CPP statute. And I recognize that sometimes it's that those things, qualifications may be in a statute because that's what you had to do to get it passed. I understand that, but that is certainly not a reason to open up your proposals in a sort of a defensive way, or as I say, leading with your chin to say, well, give us collaborative practice, but let me anticipate every objection you might have, or let me anticipate every individual parade of horribles example I can think of, and let's be sure we put all of those things in the statute so that the 1 in a billion occurrence will never happen, or that we appear to be paying appropriate deference to physicians or whomever it is. Get your authority stated in a clear way that builds sort of the framework of the house. That's all a statute is ever supposed to do. Now, the rulemaking process, whether we're talking about by boards of pharmacy or any other administrative agency, the whole purpose of that is to fill in gaps, to provide that level of detail that the profession believes needs to be there to put some, the shingles on the roof or the drywall on the wall of the framing, to make sure you can actually give folks the guidance they need to be able to operate. And that's done by administrative agencies because they're the experts in the field, right? They're the ones who are charged with saying, knowing what we know about our profession and applying our expertise, we think these are the kinds of pieces of more specific guidance that need to be in place. You really don't want to be asking generalist legislators to get into that level of detail. That's no criticism of legislators, but they are generalists. I mean, there is a pharmacist, of course, in the North Carolina General Assembly now. There's a physician in the North Carolina General Assembly, but the vast majority of those folks don't have any real appreciation for what the profession is. So get your authority in broad strokes from the legislature. Then you look to the rulemaking process to fill in the gaps as needed and provide some of that detail. But then even then, I would say, when it comes to things like professional practice, there really ought not to be a great need for a lot of highly detailed rulemaking embroidery on the statute. Look, either we believe and can advocate that pharmacists are trained clinicians who are capable as competent, trained healthcare practitioners to have discussions with competent, trained physicians and decide, here's what we're capable of doing together and here's how that's going to work, or we're not. And if we are confident in those things, as I think we should be, you don't need to lard up, certainly not in a statute or even in a rule, a whole lot of highly detailed sign here, X number of A's here, or to use the great example from the existing CPP, patient-specific, drug-specific, disease-specific sort of agreements. It's that, again, I don't want to be overly critical of the old act. I imagine that's what was necessary to get it passed at that time. Let's not, if we are fortunate enough to get an expanded collaborative practice agreement, let's not sort of import anxieties that folks may have about individual circumstances into a statute in a way that inevitably creates unintended consequences, and in all events acts as a real barrier to practice advancement. Practice advances because of the skill and quality of those who practice it, exerting that skill in new ways. Practice does not develop at the stroke of a legislative pen. So let's be sure that a statute allows the clinical aspects of practice of pharmacy to breathe, develop, and grow, just as the clinical practices of medicine, psychology, you name it. We are a healthcare profession. Let's be comfortable with the fact that as healthcare practitioners, we don't have to follow a detailed checklist to do the things that we've been trained to do.
Thank you, Joe. Our next question is for Mollie Scott, but I'm going to also ask Christie if she would comment on this question as well. One of the concerns raised by a few people is the ability for new graduates to collaborate. And assuming that a physician would be willing to engage in a collaborative practice agreement with a recent grad, what are your thoughts on how graduates are prepared today for practice? And are these individuals important for the workforce as it relates to providing patient care services that might fall under a collaborative practice agreement?
Penny, I think that's a really good question, and it gets to the heart of how pharmacy students are trained in 2019, compared to how folks have been trained in the past. And in my mind, this is not just centered around the idea that all of our pharmacy graduates are now getting their Doctor of Pharmacy degree, because certainly we have pharmacists who do not have PharmDs and who are bachelor's level trained pharmacists who have been very successful CPPs in the state. So I don't think this is really about the degree itself. I think it's really about the philosophy of care and the skills and the knowledge that pharmacy students are gaining in their educational programs. You know, one argument has always been made about how much pharmacotherapy training that pharmacy students get compared to other professionals. And I can remember a day in my own career where I was doing some teaching for PA students at a university, and I'm teaching them how to prescribe, even though that's not a skill at the time through pharmacy practice regulations that I was allowed to do, and yet I was teaching them how to do it. And so certainly we do have a lot of pharmacotherapy training, but you know, I think even more importantly than that, one of the things that our profession is really finally getting our minds around is what is the process of care that pharmacists go through as they're taking care of patients. And so if we think about the JCPP documents around the pharmacist care model, what are the steps that we take systematically to take care of patients? That's really the art of pharmacy. And then also, you know, with some of the work our national organizations and some grants have done around defining what is comprehensive medication management and what are the elements of that. Our students are learning those things, and they're learning how to communicate effectively with patients, how to work collaboratively on teams, how to select medications appropriately, how to order laboratory studies, and how to interpret those, and all the different processes of care that you go through to help your patient be successful. Now, when they graduate, does that mean that they are capable of being in any type of environment where they're asked to use their CPP? You know, I'm thinking about the bread and butter things that any pharmacist should be able to do related to things like immunizations, hypertension, asthma, common chronic diseases. You know, perhaps that's different than the pharmacist who's working in neurotrauma ICU, you know, managing insulin drips and managing all the different medications in that environment. And so I do think that there are things that our new graduates could absolutely be qualified for, especially if they have been through programs as part of their education where they've seen the team-based care CPP model. They understand what that is. And for instance, you know, in order to do immunizations, there's an immunization training program. Other states have done that as well for different statewide protocols. And we need those new graduates in order to be able to reach a broader number of patients. Now, the other side of that coin is that we will need to do some own determination as a profession and probably as organizations about what kind of credentialing that we want for pharmacists when they are hired to do certain tasks. So for instance, with our own CPPs at MAHEC, I'm actually not credentialed to do the medication assisted therapy for opioids because that's not something that I know very much about at all. And so you wouldn't want me coming in providing that service, but I am credentialed to come in and do a lot of other things around osteoporosis care and other chronic disease management. And so as we think about our profession, rather than dictating all the different hoops that people have to jump through, as Jay was talking about in statute or even in regulations, I think that we will have to decide as organizations what type of folks are we looking for to do the job that needs to be done, recognizing that today's graduates have that good understanding of a process of care, team-based care. They understand comprehensive medication management, and let them do what they're trained to do. And if you have very specialized areas that you want to put a pharmacist in that they've not had specialty training in, then you rely on our state organization. You rely on continuing education programs to figure out how to fill in those gaps, and some of that will be regulated within the profession rather than dictated by statute.
Thank you, Mollie. Christie, what are your thoughts on that?
I don't know that I have much more to add because Mollie, of course, speaks so eloquently to the full spectrum of the process. I think our students do, when they're coming in, they see what is possible. They get the opportunity to rotate through lots of amazing rotations represented by all the folks that are on this panel. And if our legislation is hindering us from our learners being able to go out and grow the profession, I think we are doing ourselves as the pharmacy profession a disservice. So I think as much as we can encourage this collaborative practice, this change, this expansion, it only helps our learners. And again, as Jay was saying earlier, from a regulatory perspective, then we figure out those nuts and bolts, just like any other healthcare profession, in terms of determining who's able to do this type of therapy, this type of care, instead of trying to dictate that in one large jump swoop.
All right, thank you, Christy. So our last question for the hour is actually for Lisa, Christina, and the question is, can you describe how our existing collaborative practice statute and rules now has stymied innovation or has created a barrier to care for your specific practice setting? And then, do you believe that the changes that are being proposed for the bill that we're talking about would actually resolve those barriers?
You want to go first on this one?
Yeah, sorry, Lisa. Yeah, let's have you go.
Sure. No problem. I first have to sort of give a shout out for all of those pioneers. I was just thinking about all the pioneers that put the CPP into place. And I remember thinking when I first got out of school and got into my role in ambulatory care and became a CPP, and that's really the only practice model I knew because I did a residency with the CPP. And so that was sort of my world. And to get into practice and realize other people don't have that access point in ambulatory care or other settings, or I could just, I could fix things for people. And having those people as my touch points, I didn't have those once I got out in practice. And so it was really eye-opening for me. And so I have to just give a shout out to all the pioneers, to get it into place and to, I think Jay mentioned earlier that we had 0 to 1 episode of anything alarming happening to these people for patient care related activities. And so that speaks volumes to me because that's 20 years of data. So I want to say thank you to all of those people out there. I'm very lucky that I do get to practice in an environment that the limitations of the CP hasn't really impacted me personally in my AmCare practice. However, I think about other areas in the health system that I work in that it has been greatly impacted. And think about, what could have been. I think, in our transitions area, I think that's a great opportunity to have this collaborative practice. I think about in multiple transitions in multiple aspects. So patients that get discharged from the hospital and then need follow-up care in a short period of time, again, before they can get back into the provider's office. Right there's a great opportunity that's missed. Long-term care facilities as well, when patients are transitioning into those environments. I think we don't even know the possibilities, what that could have happened in those areas. Qualifications have been probably, I think, they're even intimidating for me. I have been through the process. People ask me sometimes, what are the qualifications? I can't remember them all. Can't remember how to get there and how I got there because, again, I was embedded. I was in this perfect world in my mind, so I didn't have to work hard at those, but other people I know have given me feedback that it's very intimidating, that you really have to be set up for success in an environment like that to become a CPP. And so why wouldn't everybody have that same chance when they graduated or same opportunity to establish those relationships? It shouldn't be just that that innovation being dictated by the legislature as we have it now. I do think we have one area in our hospital that I'd like to highlight, or our health system, if you will, I'd like to highlight that is sort of that integrated practice model, and it's with our community pharmacy. We have an outpatient pharmacy. And over the last couple of years, when we gained access, when they gained access to the electronic medical record, that opened up an entire new world for those pharmacists and our patients, because they could actually see in the record and see, oh, they have already had a flu shot, or they've had a pneumonia vaccine, or this is the dose that they were supposed to be on. And so they could fix lots of problems, anticipate problems, prevent problems. And it has been a really great thing. Again, I'm sort of sheltered within our healthcare system, but I always think about the community pharmacists that work all across the state that don't have access to those records. So they're asked to practice or to take care and treat patients without full access to all disease states, possibly. They don't have the information they need. So to me, I think this, by modernizing the collaborative practice agreements, could open up all kinds of new business models just by having access to patients to collaboratively take care of those patients and improve that care.
Unfortunately for us, it has been a barrier in several ways. I think Christy had talked a little bit earlier about when you have multiple providers and you've got multiple pharmacists, how do you go about setting up an agreement for each patient, each provider, each pharmacist? So because we work with a hospital and several multi-physician group practices, it's just been, I think the burden of work required for that has just been overwhelming. So nobody's even thought about pursuing that down the line. So the other side of that, of course, is that we've had a number of mid-levels who have different practice capacities and different businesses of their own who've approached us. We've had home health, we've had long-term care, we've had SNFs. They've all approached us, and we're sort of saying, okay, well, you have a mid-level. Sorry, we really need to look at a physician. So there are a couple ways that that's been a barrier, and something that Lisa just said, it just lit a fire, I think, within me. There is not a day that goes by that we do not say, how did we ever get on without access to the EHR? And there isn't a day that I think about my colleagues who are dispensing who don't have access. And I think of the safety issues. And pharmacists have been cut out of this equation for so long. And I spent the better part of my 20 years practicing without access and relying on somebody to tell me about a patient. Suddenly, when you've got EHR access and HIE access, and you're seeing the full picture of your patient, you're realizing, to answer the question, Penny, not only are we expanding care opportunities, but we're also improving safety. And there are multiple opportunities for pharmacists to jump in and really help patients in, somebody said, we don't even know what's out there, Lisa had said earlier, because we don't know what we don't know. And I think all the time about all of my colleagues who don't have access, and I think it's amazing that there haven't been more issues, and it's wonderful that there haven't been, but think about all the good we could do if we can expand this. And so, yes, it's been a barrier. It's one that we think about all the time. We've still been able to do some things without that, but boy, it would make a tremendous difference if we could have that in place. And I think if we had a broader, if we were able to expand that collaborative practice agreement legislation.
Well, thank you. I think at this time, I'll just, we've touched on a number of different elements through a series of questions related to the bill. At this time, I just open it up to if there's anything pressing that you feel like we missed, or that you, a closing comment that any of you have. I'll give you that opportunity before I close out the session. Okay, looks like everybody's quiet. And so once again, thank you so much for participating. And I can't, I really think sharing your perspectives, all of you are recognized leaders in our state. I thank you for the work that you do for patients every day. And in the case of Mollie and Jay, although Mollie, you do have some patient care, I thank you for the work that you do on a more of an administrative level. And that's all. I'm going to go ahead and close out and end the meeting. And I thank you again for your time.
Thank you, Penny.
You're welcome.
Thank you.
Thanks.